Here is a dynamic look at the movement of the neck in flexion and extension. You can see the cervical and thoracic vertebrae slightly in motion, however, staying in place, as opposed to the oral cavity proper, including the tongue and the extrinsic muscles, all which pull the endotracheal tube either up with extension or down with flexion. A good way to remember this is to think about this saying, hose follows nose. So here's a case study on a 27-weeker, birth weight 750 grams, intubated March 11th, secured at 5.5 at the gum. 18 days later, on the March 29th, patients corrected 29 and 3, 955 grams. Per report from night shift, 2.5 tube, retaped with the last 2 top layers, secured at 5.5 at the gum. Last x-ray shows good position at T3. This is the x-ray prior to unplanned extubation. We see 5.5 centimeters documented at the gum. Last x-ray, March 28th. When looking at this x-ray, you can see that the chin is down, pulling the ET tube lower and making it look good at T3 on the x-ray. There is an unplanned extubation event on first cares after the care team turns the patient's head and notices vent alarms with 100% leak. Patient is re-intubated with the same tube at 6 at the gum. X-rays taken with the chin slightly too high, visualized as 6.0 at the gum. Per doctor, ET tube is retaped to 6.5 at the gum, and the head is held in a more neutral position, sniffing position, not too high, not too low, and looks good on x-ray. This is the tool that we should be looking at prior to starting the shift. 955 grams should have prompted the care team to consider advancing the tube to 6.5 at the gum.